Now going to review our master class of the day. Now I request Professor Piyush Kanti Mondol, who is the Professor of Medicine, Malda Medical College, to introduce today's chairperson. Piyush, please.
Thank you, sir. At the outset, I am thankful to Dr. Amol Kumar Banerjee, who is the course director of this program, Master Class, API, organized by APIWB West Bengal chapter and West Bengal ICT Forum. It's my proud privilege to introduce Professor Udas Chandra Ghosh, who is an astute clinician. He is the teacher in my college days. He is the past Joint Secretary of Indian College of Physicians. He is the past Secretary of API West Bengal chapter, ex-HOD of Murshidabad Medical College, from where Dr. Hamid Ali is hailing from. Dr. Ghosh is acting as Professor of Medicine right now at Medical College, Kolkata. Presently, he is the treasurer and a key person of API West Bengal chapter. Right now, he is an elected governing body member of Association of Physicians of India. With these few words, may I hand over the mic to Professor Udas Chandra Ghosh for the proceedings, please.
Thank you, Piyush, for your nice introduction. First of all, good morning to all my seniors. My sincere regards to all the seniors, particularly Dr. Amal Kumar Banerjee, Dr. M.K. Rai, Dr. S.B. Ganguly, and others, Dr. Shivendu Ghosh and all others. Today, actually, we have decided to give a lecture on anemia, because we the physician come across daily with different types of anemia and different case of anemia presented differently. And so we have chosen a person which is nearly a pivot of Murshidabad Medical College, Dr. Hamid Ali. Dr. Hamid Ali is a good teacher, is a good doctor, and even a good man also. When I joined in 2013, and Dr. Hamid Ali has taken all the logistic, academic and all other responsibilities from my end to run the hospital very smoothly. I'm really thankful to Hamidi also. And he is now the secretary of API Murshidabad branch, and he is also secretary of APM Association of Physicians of Murshidabad. And not only that, he takes the all responsibility of the undergraduate classes in Murshidabad. And really, he is a good orator also. And now he will speak about the different cases of anemia and how you interpret, how you rather diagnose the cases of anemia from clinical and some laboratory tests. Hamid, please, you may start now.
Thank you, Chairperson, for your kind introductions. And I am very thankful to the organizer, the West Bengal ICP chapters. And without wasting time, I am going to present my case. At the outset, I want to say something, only a few points. That is that I'm not a hematologist, and I have tried my best to collect the cases from different sources, from my own source, as well as from a hematologist, Dr. Prakash Kumar Mondol. And with the help of this, and I tried to I tried to present, make these presentations. And now, before going to the case presentation, I will want to share some introductory slides, what is the anemia and how will you approach in general cases. So anemia is defined as the different by any of the following. In men, hemoglobin less than 14, hematocrit 42%, RBC less than 4.5. In women, it is less than 12, hematocrit less than 37%, and RBC less than 4 million. Now, this is the slide. We can the blood RBC is produced in the bone marrow with the help of the ferritin, globin, vitamin B12, erythropoietin, and that ultimately is also gets break down in the reticuloendothelial systems, and ultimately the heme and globin get separated, and this globin is separated, and heme ultimately give rise to the bilirubin, and which causes jaundice. Now, red cell production, there are hematopoietic stem cells. From these, the BFUE and CFUE is produced. From the erythroblast, ultimately comes the reticulocytes, is the premature RBC, which has the RBC, the RNA molecule is there, and the mature RBC does not have any RNA molecules. So up to the erythroblast formation, there is a role of erythropoietin, but after that, the role of iron is very, very important from erythroblast to mature RBC formations. The symptoms of anemia is a very, very myriad. There are so many components are there. The general component is that the decreased oxygenation leads to the exertional dyspnea, dyspnea at the rest, fatigue, bounding pulse, lethargy, confusions. And because of the decreased volume, there may be fatigue, muscle cramp, postural dizziness, syncope. But anemia is a general symptoms, but any patient comes with these symptoms, usually you test for the anemia. But there may be cause-specific symptoms, maybe bone pain, maybe signs of thrombosis, maybe some bleeding, hepatosplenomegaly, lymphadenopathy, frequent infection, non-specific skin lesion, and neuropsychiatric symptoms all are related to the anemia. So angular cheilitis, we know about this is a very common, we often sees in a case of iron deficiency anemia or any anemia presents with the pallor. There may be associated depression, thus may be fatigue. So depression, fatigue may be a presentation of the anemia. And the easy fatiguity, running out of steam, all are features of the anemia. So anemia may present like a depression, may present as a fatigue, like this are psychiatric symptoms. So any psychiatric symptoms present, if you even fail to diagnose a case of anemia by clinically, you must ask the patient to do the hemoglobin test. Now, when the patient comes with the symptoms of anemia, and the first part is the history to be taken. What are the points to be taken care? One point is the risk factor for particular anemias, there are not. If there is any risk factors, your diagnosis will be very easy. Then the symptoms already mentioned, and specific symptoms, basically not the generalized symptoms, the specific symptom is there or not, and the symptoms that reflect the underlying disorder. Now, at the outset of the evaluation, you must think whether this anemia is the acute or chronic. There is a differences is there. Whether any medications or drugs that causing, the medication or drugs that cause the anemia. So you know some drug causes the anemia, and that is not related to the acute condition. If it is acute condition, we must think of the G6PD deficiency. And if it is not related to the acute condition, a little bit of some subacute or the chronic condition, then maybe an other causes the autoimmune hemolytic anemia. Or if there is an anemia in the family history, if it is family history is there, we must think of the genetic disorder. And this is very important. The concomitant medical illness, past history of any collagen vascular disease or are the malignancies there or not. If you get it, your diagnosis will be very easy. And the clinical presentation is also very important. Now, suppose the risk factors of anemia, what to be taken care. For example, a vegan diet predisposed to the development of the vitamin B12 deficiency anemia. A alcohol use person, they actually have a folate deficiency. Hemoglobinopathies are inherited. Certain drugs and infection predisposed to hemolysis. The most important drug we know all about is the primaquine, when given to a G6PD deficiency patient, usually causes hemolysis. There are so many drugs are there. Naphthalene is there. Sulfur drugs are there. Even the nitrofurantoins are there. If the patient having a malignancy, chronic disorder, collagen vascular disorder, or the chronic inflammatory disorder, they are usually produced. We usually think of the anemia of the chronic disease. And besides this autoimmune disorder, SLE, lymphoma, autoimmune hemolytic anemia is another points. Now you have to find out the cause specific or the symptoms that suggest a cause of anemia. Suppose a melena is there, epistaxis is there, hematochezia, hematemesis is there, menorrhagia is there. That means every anemia patient, when you evaluate, you must think of the any bleeding is there. This is the first and foremost important thing for the evaluation of the anemia. The bleeding is there or not is a very important point. Then you must look for the jaundice is there or not, dark urine or yellowish urine is there or not. If the anemia with the jaundice and the dark urine in the absence of liver disease is almost suggestive of the hemolysis. If there is a weight loss, you may think of the underlying cancer is the cause of the anemia. Diffuse severe bone or chest pain may suggestive of sickle cell disease, though it's rare in our in this area. But multiple myeloma is also an important diagnostic point. And as well as even the patient having a severe low back pain, so it may be a case of ankylosing spondylosis. Stalking and glove paresthesia may suggest the vitamin B12 deficiency. If there is a neurological symptoms along with that of the anemia, you must think of the TTP is maybe the one of the important diagnosis. And if the anemia is associated with the renal disease, and if the patient has a history or past history of the GI tract infection, urinary tract infection, even the upper infection of E. coli, and the now present with the anemia and the renal disease, renal failure, renal involvement, you must think of the hemolytic uremic syndrome, Henox-Kunlian purpura or hemolytic uremic syndrome. Or the TTP is not a very acute, but if the patient present with the renal disease with anemia, neurological disease, the TTP is always there because of the thrombosis. So first point is the bleeding is there or not. It may be obvious. Whatever the case has been discussed till now, that an obvious cause of bleeding has been mentioned. But sometimes you may not get any bleeding, but the patient have an actual bleeding, the occult bleeding is there. In that cases, you must do at least try to find out the stool for OBT or urine for REME, whether there is an hematuria is there, occult hematuria is there, occult bleeding in the GI tract is there or not. So these are very important. Obvious bleeding or the occult bleeding must be excluded at the first visit of your evaluations. Then already this part is already mentioned. I'm not going in details. If the bleeding history in the skin, petechiae, purpura, ecchymosis, the hematrosis, hematoma, you can think of so many things. You may think of the coagulation disorder may be the cause of the anemia if there is an petechiae, purpura, and hematosis. So coagulation disorder is leading to the bleeding. Now, there are some patients I have faced, this is my personal experience, that a patient present with the acute severe pain abdomen and suddenly collapsed down, comes as a syncope and presented to the department, emergency department, and it found the patient is profoundly anemic and patient is in shock. And ultimately the case came out to be a case of rupture aortic aneurysm. This is very important. It's a severe pain abdomen with a shock, with anemia, there is a rupture aortic aneurysm. Or one case was, I also faced it, the acute peptic ulcer bleeding that leads to the anemia. The initial part, there is no hematemesis, no melena was there in my cases. Signs of underlying disorder, yes, so already mentioned occult blood test should be done. An hemorrhagic shock may result from the acute bleeding. Be careful about this. And in that cases, you may not find the anemia. Be careful about this in the patient having a shock. But if you test the hemoglobin within 1 to 2 hours of your presentation, you may not have the anemia in that cases because it will take some time, 24 to 36 hours, to blood to be diluted and gives the result of hemoglobin low. And if you find the jaundice, already mentioned hemolysis, splenomegaly is also again is a cause of hemolysis as well as the hemoglobinopathy. It may be associated with the connective tissue disease, collagen vascular disease, and the myeloproliferative disease, CML, CLL, And like this myeloproliferative disease infection, among the infections, splenomegaly infection with anemia, you must not forget about the malaria, and the malaria. And if the patient is the chronic, then the kala-jar, and kala-jar should not be forgotten in the background of the anemia with the splenomegaly. Is very important point. Peripheral neuropathy, if there is always has B12 deficiency, fever and associated heart murmur, we know that may be case of infective endocarditis, or if the patient has undergone surgery and have valve replacement, metallic valve replacement, MVR or AVR done, there may be possibilities of the hemolysis, that is microangiopathic hemolytic anemia may be the cause. So the blood loss may be acute or chronic, or other anemia. This is the already I am giving stress on this point, because this is the most important point, and you will most of the cases you will get a diagnosis. Now the second point, why the patient having diabetic, patient having anemic. Then you must have to think of the deficient erythropoiesis. Mostly they are problem in the formation of the erythropoiesis, RBC in the bone marrow, or there may be ineffective erythropoiesis in the bone marrow, in like that of case of megaloblastic anemia. Or if the blood, the RBC is produced, but it is being excessively destroyed, then we will think of the excessive hemolysis is one of the important cause. Now, when you think of the excessive hemolysis, what are the points to be taken care? One point is it may be the intrinsic abnormality of the RBC, or by the extrinsic factors such as presence of autoantibody against the RBC, and that cause early destruction, that is autoimmune hemolytic anemia. Or an enlarged spleen may actually sequestrate and destroy the RBC more rapidly than the normal, and some causes of hemolysis deform as well as destroy the RBC. And hemolysis normally causes increased reticulocyte production. It's very important. So if there is an hemolysis, that means associated jaundice, splenomegaly is there. Along with that, you must in the peripheral blood smear, you will have an increased reticulocyte. Now, what are the other testing in anemia? Now the clinical history has been well taken care. Now we go for the testing. The most important, the CBC is very important. RBC indices and the morphology to be taken care, reticulocyte count, and the most important for the anemia evaluation, the peripheral blood smear. Most of the time, we do not mention about the peripheral blood smear examination in a case of anemia. But when a patient comes to you and you advise for anemia, you must ask the patient to do the CBC as well as the peripheral blood smear examination. You write it properly. Sometimes this is the clue. This gives the many clue to your diagnosis. And rarely, sometimes not usually needed, bone marrow aspiration and biopsy are required. Now, mostly a few topics about the RBC and the PCV. Is RBC low, usually low, PCV usually low in the anemia. So most often it is low. If you consider the WBC, there may be in acute viral infection with anemia may be low, but if the chemotherapy, drug-induced AIDS, all the cases may be low. In other cases, may be low is the aplastic anemia, MDS, subleukemic leukemia, and megaloblastic anemia is also important. SLE, typhoid, malaria, TB, dengue, sepsis, all may present with anemia, and in that cases, you may have a low WBC count. Beside the common diagnosis of aplastic anemia and the myelodysplastic syndrome. If the patient having a high WBC count, always think of a reactionary lymphocytosis that may happen in many cases. One of the causes is the iron deficiency anemia, where you can have a little bit of high WBC count, not very high, but usually high. And the bacterial infection, leukocyte reaction, leukemia, myeloproliferative disorder to be taken care. Monocyte usually high in a TB and fungal infection, but if it is very, very high, it usually gives a diagnosis of monocytic or myelomonocytic leukemia, but monocyte may be high in the collagen vascular disease, is mild to moderate range. Eosinophil is high, only it can be a hypereosinophilic syndrome, but most of the cases it is because of the worm infestation that can lead to the anemia, or the fungal infection, or because of the allergy. Usually they do not have an anemia. But myeloproliferative disorders should be considered when the eosinophils are not mature, it is immature. And all the other cases are the high eosinophil counts are usually mature, but here in the myeloproliferative disorder or eosinophilic leukemia, in that cases, the usually eosinophil looks immature. Now, yes, sir, in anemia, most of the cases, ESR is always high because of the low RBC volume. In most of the cases, degree of high ESR in anemia because of it depends with the correlates with the anemia level. But it gives false impression of infection or inflammation or malignancy. It does not actually depict anything because the ESR is high only because of the anemia. But if you think of the persistent ESR more than 100 with anemia persisting, it is suggestive of multiple myeloma or TB elsewhere in the body. Now, the most important parameter of RBC indices is the MCV. It is 80 to 100 for practical purpose, we take it as 80 to 100 femtoliter. Now, the MCV, usually in the low, we know the iron deficiency anemia, thalassemia, sideroblastic anemia, but the MCV is high in mainly the primary bone marrow disorder, megaloblastic anemia, and the alcohol is also an important point. Alcohol, hypothyroid, as well as the hemolytic anemia. This also causes the high MCV. Usually we get a normal MCV in a case of anemia of chronic disease. Now, MCH and MCH is basically MCH dictates the hypochromia or not. Is a low is iron deficiency anemia and normal in megaloblastic anemia and macrocytic anemia. In macrocytic and megaloblastic anemia is usually low. And only rarely MCH elevated in if you find the MCH is high with the background of anemia, you must think of whether it is a case of hereditary spherocytosis or not. It gives a clue. The anemia with a high MCH is a hereditary MCH. Sickle cell disease, homozygous hemoglobin C disease is also another, the most common 3 causes. Now, RDW is another parameter, very important parameter. It is actually differentiates of iron deficiency and the anemia and the thalassemia minor. So, is actually normal means the uniformity in the size, abnormality means the not uniform in the size. Now, with the background of the low MCV, RDW is normal with a low MCV, then is usually there may be an the most important is the RDW increase with a low MCV is the iron deficiency anemia. But when RDW is high, but the MCV is high, so this part is actually differentiate. The low MCV is there, it differentiate high RDW means iron deficiency anemia. But when high MCV is there, and as well as RDW is high, then you think of it may be case of megaloblastic anemia, pernicious anemia, and myelodysplastic syndrome, or it may be as a secondary to the chemotherapy. The platelet count, usually if you find the platelet count is low, you think of the ITP, TTP, HUS, and HELP syndrome. Or even in acute leukemia is also an important parameter. Aplastic anemia is also important. Lymphoma is also important. Drug therapy, chemotherapy, radiotherapy, and even nothing related to the hematological system, but is the high cirrhosis with a very high, large splenomegaly, they actually sequestrate the platelet in the spleen, and that causes the low platelet count. And nowadays, we do not forget about the low platelet count with anemia, with the dengue, malaria, and the typhus. Another important point is the reticulocyte. Reticulocyte count is very important. It informs about the response of the bone marrow to the anemia. It differentiates between the deficient erythropoiesis, usually with the excessive hemolysis. So reticulocytosis means the excessive RBC destruction, and low number means decreased RBC production. Now, reticulocyte count. There are some fallacies. There are reticulocyte, usually we express in a percentage of immature RBC. It usually 0.5 to 1.5%, but on practical purpose, when there is an anemia and the reticulocyte count is less than 1, it indicates the inadequate production. When it is more than 1, it indicates the increased production. And if you go through the peripheral blood smear, you can go and see the blue staining of the reticulocytes of the RNA molecule of the RBC. Now, percentage of reticulocyte count actually overestimates. Now you need to the correction of the reticulocyte count, and that should be compared to the non-anemic RBC, and that's why the corrected reticulocyte count should be measured, and it is usually the percentage with the hematocrit by 45 or hemoglobin by 15. Now, reticulocyte production index is an RPI that actually is a percentage of reticulocyte count by hematocrit by 45 into 1 by divided by the correction factor, or we call it the maturation factor, and maturation factor depends on the degree of the hematocrit. This 1 to 2.5, and if the RPI less than 2, you think of is a hypoproliferative anemia or defective RBC formation. And if the RPI is 2, we think is a hyperproliferative anemia. So reticulocyte count, cutoff is taken 1, but when you calculate the RPI, it is actually 2. Cutoff is the 2. So with this background, reticulocyte production index is less than 2 means hypoproliferative. These are the causes, mainly the fuel of the erythropoiesis, iron, B12 deficiency, as well as chronic disease, aplastic anemia, myeloproliferative disorder, and hyperproliferative or RPI more than 2. In that case, is most important, the hemolytic disease, hemoglobinopathy is also there. Now, another, when the patient comes with a hemoglobin, low hemoglobin, you are thinking of the MCV and MCH, and then is the reticulocyte count to be considered. If the reticulocyte count is low, then there may be, and if the serum B12 is low, then megaloblastic anemia should be another cause. And if the reticulocyte count is increased, you must think of the blood loss or hemolysis. And the MCV, when the MCV is low, then again MCV is low, look for the reticulocyte count. If the reticulocyte count along with that reticulocyte count decrease, along with the serum iron, ferritin, TIBC is low and TIBC is very high, then is at iron deficiency anemia. But when the reticular is with the background of the MCV, low MCV and the low high reticulocyte counts, then the chronic blood loss and hemolysis is the cause of the anemia. And when there is an RDW is normal with the low decreased MCV, then consider the thalassemia trait, hemoglobin electrophoresis to be done. So bone marrow aspiration usually do not done. It can be done in a case of unexplained anemia, more than 1 cell lineage abnormalities, and suspecting primary bone marrow disorder, and then you may have a bone marrow biopsy is also required. Cytogenic and molecular studies are not required when you think of the malignancy or some sorts of related disease. Then you can think of the cytogenic and molecular studies. So, and the last test is also important, whether the evaluation in the evaluation of the anemia, the hemolysis there or not. So serum bilirubin, LDH is very important, and the B12 folic acid level to be measured in a high MCV, iron binding capacity, and other tests as per the disorders. And the test for bleeding disorder is also to be noted if there is suspected of the deep bleeding is there. Peripheral blood smear is very, very important. Automated cell counter is most of the time you may take the help of the automated blood counter, but you must see the peripheral blood smear in a case of anemia. So the shape given, if you find the spherocytes, it usually indicate the hereditary spherocytosis, or it may indicate the autoimmune hemolytic anemia. If you find the cystocytes with the thrombocytopenia, so mostly with the hemolytic uremic syndrome, TTP or DIC, if it is cystocytes without thrombocytopenia, it may be the heart valve hemolysis or heart valve replacement. Blister cells usually you find the oxidative damage because of the G6PD deficiency to the drug exposure. Sickle cell disease, you can find the sickle cell or henge bodies, you can find in the alpha thalassemia and G6 deficiency. But this is so many lists are there. I have given a few of them. Now, the therapy, I will not go in details. Mostly in iron deficiency anemia, oral therapy, either ferrous sulfate, ferrous fumarate, ferrous gluconate, iron iron in different form. But IV iron, iron sucrose, FCM, isomaltose. Nowadays, it has been shown, in different study has shown that the oral iron may not be the first line of choice. In some situations, this IV iron may be the first line of choice. Thalassemia, the folic acid and the genetic therapies, or bone marrow transplantation if required, megaloblastic anemia, the methylcobalamin, folic acid. And if you think of the autoimmune hemolytic anemia, the steroid is the main corner of therapy. ACD, you must say most of the cases CKD, and then you will have to give the erythropoietin, darbepoetin, and along with the iron therapy. And the most important part I have mentioned here, APML, acute promyelocytic leukemia. Here, the very important, when you suspect a case of APML or you have diagnosed a case of APML, you jolly will start the ATRA therapy immediately and send the patient to the hematologist. So APML patient has a very good prognosis with the ATRA and other therapy, but ATRA therapy must be given without any delay. So RBC transfusion should be reserved for the following patient, but I know that we all have a very, very bad experience. Any patient of hemoglobin 5, 6 and comes for blood transfusion in the hospital, and we are bound to give it, and we actually may delay the diagnosis. Now, the first, the case presentation, the 18 years old female patient presenting with the easy fatigability and breathlessness. And on examination, pallor, plus, no icterus, no organomegaly, no lymphadenopathy. So only anemia is the diagnostic. Now, some of the clinicians, patient gone to the clinicians and he advised hemoglobin, TCD, CSR and the platelet. And this comes to be like this. What next? The problem, you can see that I have diagnosed the anemia clinically and it tells that it is 5 gram per cent. And no other parameter is very, very suggestive of any disease. So what next? This is the common mistake we often do. And that's why I have given this. So what next actually? What should be done in these cases? Actually, the clinician failed to give a proper diagnostic test. It should be the complete blood count. Now, this is the scenario of the patient. Now we can see his MCV is the 62 femtoliter, low MCV is there, and MCH low. So hypochromic and microcytic anemias. They are on the background of anemia without any hepatosplenomegaly, lymphadenopathy. So probably we are dealing with a case of iron deficiency anemia, or very close diagnosis is that of a thalassemia minor, because the thalassemia minor and iron deficiency anemia clinical picture is very close to. Then what is the next clue that will help from iron deficiency anemia to the thalassemia minor? Probably we need an RDW here. Here the RDW is 18.2% and it is high on the background of the low MCB. Probably we are dealing with a case of iron deficiency anemia. But here we are lucky enough. Someone has raised a question. Should I take it?
Hello, better to check the later.
Okay.
There is some other question, you just continue.
Okay. So in their cases, suppose the case of RDW is not very clear. RDW is in the range of 14, not very high. So diagnosis may not be clear in this background. So now, there is a possibility of this iron deficiency anemia and beta thalassemia. Now there is another parameter is there. We often take the help of the iron studies. So serum iron, ferritin was low and the TIBC was high and transferrin saturation was low. So likely it's a case of iron deficiency anemia. But when the MCB is low and you do not have the iron parameter, you can have the reticulocyte count. If the reticulocyte count is low, and you also the Menjar index. Menjar index, if it is more than 13, is usually suggestive of iron deficiency anemia. So Menger index is nothing but the MCV by RBC. If it is less than 13, signifies the thalassemia trait, and more than 30 signifies the iron deficiency anemia. So diagnosis is the iron deficiency anemia here. So this is the normal peripheral smear, and here we can see the on the right hand side you can see the hypochromic microcytic RBC. Here you can it is very clear to the peripheral blood smear. Now these are the parameter. I'm not going in details. Patient has the ferritin level. Now another point is that whether there is an anemia with the ACDs there or not. Now ACD also comes with the anemia. The chronic disease also comes with that of the low MCV. IDA is also low MCV. But whether there is an associated iron deficiency there or not, sometimes it's very difficult, because the ferritin is a acute phase reactant protein. It is always high in a case of ACD, and in IDA it is usually low. But the ACD patient with the having a high ferritin, whether they have an actual iron deficiency or not, in the clinical, in the practical formula is that if the ferritin is less than 100, you can normally, normal patient, you can jolly well, you can take the iron deficiency anemia as a cause. But when there is 100, you can exclude the iron deficiency as a cause. But in a ACD, here, if the ferritin is less than 100, less than 200, you can think of the iron deficiency along with that of the ACD. Or if it is more than 500, you can exclude the iron deficiency. Now, another point is the iron. Iron is always low in all the conditions, ACD with ID or in the both the conditions. But theoretically, there is a role of soluble transferrin receptor, which is usually raised in a case of IDA. And if you go for the STFR with the log ferritin, it is more than 2 in a case of IDA and less than 1 in a case of ACD. Now, even in that cases, if you want to meet the or diagnose a very early diagnosis, early iron depletion, then you can take the help of zinc, protoporphyrin, and heme ratio, which is raised in a case of early iron depletions. And even in that case, the anemia with the chronic disease, with that of the iron deficiency anemia, whether they are coexisting or not, you can take the help of hepcidin, which is decreased in a case of IDA and increased in ACD. And very rarely we need a bone marrow, where you can see the normal bone marrow with the iron content, here the iron deficiency without any iron contents. This is the case number 2, where the 29 years old pregnant lady, mild pallor, and physical examination normal. The same case like that of the previous one, only the pallor is there, nothing is there. And this is the parameter. Here is the, here you can, the low MCV is there, and the hypochromia is there. RDW is little bit of 16.9. The problem is 16.9. It looks like that RDW is high. That means probably we are iron deficiency anemia. But sometimes whatever guideline I have said about the RDW, if it is high is iron deficiency anemia, low is the low or normal is that of the thalassemia. Here this is the case, is not looks like this. So here you can see this is the peripheral blood smear. You can see the absent of the central pallor. In the peripheral blood smear of this patient, we can have this is the dark area. Probably this is the target cell, and this target cell actually indicate that this may not be case of iron deficiency. There may be an thalassemia. And if go for the iron parameters, and it can, so the iron is normal, ferritin is normal or mildly decreased, TIBC normal, transferrin saturation normal, Menger index is 13. So every time the RDW is not a very important that every RDW high means the iron deficiency, no other diagnosis is not like this. So this is the hemoglobin electrophoresis was done, and it ultimately comes to be a case of beta thalassemia trait. Now, another clinical point I want to mention about that, if the iron deficiency anemia is there, and suppose you have suspected a case of iron deficiency anemia, I have given iron, and the patient is not improving, the hemoglobin is not rising, this again dictates that you are not dealing with a case of iron deficiency anemia. It actually dictates you are dealing with a case of thalassemia. So this is HPLC interpretations. This is the third case, the 25 years old male, weight loss and jaundice. On examination, cheilitis, pallor, yellowish discoloration was there, some sorts of. And these are the parameter is there. here you can see the MCV is very high. So in that cases, the anemia is there, MCV is very high. Along with that, of the WBC count is low, RBC count is low. Platelet is also low. So this is a case of actually present to be a case of like that of the pancytopenia, when 3 lineage are decreased, but along with that of the high MCV. So this high MCV is very, very important. We know with the background of the high MCV, if the RDW is increased, we must think of the megaloblastic anemia. So as there is an megaloblastic anemia, myeloid proliferative disorder or myelodysplastic syndrome is the cause of increased RDW in the presence of the MCV. So that's why we tried, and there is a nucleated RBC that actually indicate the ineffective erythropoiesis in the bone marrow. So ultimately, so this could be case of megaloblastic anemia, it could be case of liver disease, or that drugs impair the DNA synthesis, or myelodysplastic syndrome. Now, these are the parameter. We thought the common disease, the megaloblastic anemia, and we go for the B12 deficiency test, and B12 is normal, folate is low. So because mostly it is an folate deficiency that causes the megaloblastic anemia. And you can think the polychromacy of the RBC on the peripheral blood smear is that is an bluish tinge that actually indicate the increased RBC production, that is with an RBC with the RNA particle. So another point on the PBC, you can see this patient having the hypersegmented neutrophil. So any patient with an high MCV with an hypersegmented neutrophil, you can jolly well confidently diagnose the case of megaloblastic anemia on the background of high MCV, even if you are not able to test the B12 deficiency or folic acid deficiency. Howell-Jolly bodies and the basophilic stippling as another findings is here. Now, another case of 14 years male, present with a dry cough for 7 days, pallor is there, and history of weakness, fatigability because of pallor, jaundice since childhood is very important, but no blood transfusion history is there. Pallor plus, jaundice plus, spleen is enlarged, liver is enlarged, hepatosplenomegaly is there, hepatosplenomegaly, jaundice, and the pallor, anemia is there. So hemoglobin is low, and all the parameter, peripheral anisocytosis, poikilocytosis is there, microcytosis there, and hypochromia is there, as well as the target cells are there, reticulocyte count is there. So obviously, and the ferritin is very, very high. So obviously it indicates it's a case of hemolytic anemia, no other diagnosis because of the anemia, jaundice, hepatosplenomegaly, high reticulocyte count, and ferritin all indicate that it's a case of congenital hemolytic anemia. Diagnosis is very, very clear with this parameter. But the problem, why the patient having a dry cough for 7 days? Yes, you can take it as a case of viral fever, influenza fever. Now it is going on rampantly. So you can take it, yes. But as the patient having a background, so we thought of some other tested, and that's why we gone for the X-ray. Now you can the X-ray, you can see that the X-ray there is a bilateral paravertebral density with a variegated shape, and MRI as well as the CT scan, you can see the paravertebral mass. So what is the import? This is not causing any bone spinal cord involvement or bone the vertebral involvement is there. Only the paravertebral mass, not having the bone marrow involvement or bone involvement, vertebral involvement. That means it's not a malignant. It's clear there's not a malignant. Though it is probably a case of lymphadenopathy or like this. So why the patient having a lymphadenopathy in these cases? So that's why actually this causes the cough. So this is nothing but of extramedullary hematopoiesis. So this could be the extramedullary hematopoiesis on the background of the chronic hemolytic anemia. But you must think of the other disease, neurogenic masses, lymphoma, paravertebral abscess, lateral meningocele. So this point to be taken care. Now, another patient of the 67 years male came with fatigue, unproportionate fatigue which is unproportionate. That is, the hemoglobin is 9. The patient is so much weak. It's not matching with that of the hemoglobin. But having hepatosplenomegaly is there, low grade fever is there, bone pain is there, night sweat is there, and the pain abdomen is also there. And the blood, only TLC normal, PLC, total platelet count, WBC normal, hemoglobin little bit normal, peripheral blood smear does not give any clue. So what is the cause? So there is here you can see on the peripheral blood smear from the total count, complete blood count, you are not getting any clue. Then in that cases, you may have to go for the bone marrow examination. And the bone marrow aspiration, bone marrow biopsy was done, and this case to be found out, came out to be a case of the progressive primary myelofibrosis. So another case is the 52 years female, weakness, fatigue, pallor for 6 months, hemoglobin 6, spleen enlarged, 3 units RBC already transfused, and these are the patient having a MCV is high. So here one point is that why the spleen is enlarged. So that's why in a case of, as this is obviously MCV is high, probably it's dealing with a case of megaloblastic anemia. But why the splenomegaly? So this is important. Sometimes the megaloblastic anemia also present with the splenomegaly, with the jaundice also. So because of the sequestration of the macrocytic RBC. So macrocytic anemia when comes, then RPI should be taken care. If the RPI is more than 2, it's because of the check out the blood loss. If there is blood loss is there, is the diagnosis clear? If the blood loss is not there, then you have to go for the Coombs test, because autoimmune hemolytic anemia also causes the macrocytosis. And if RPI less than 2, that is in that cases the check the B12 and folic acid. Usually B12 and folic acid when it is normal, then but you are suspecting a case of megaloblastic anemia, then you can take the help of the MMA or homocysteine level. And consider the liver disease, renal disease, thyroid, because hypothyroid also causes the macrocytosis. Alcohol is an important chronic disease. So these are the point. I'm not going. And this is the another case, a very interesting case. Every time this a patient presented with the weakness and pallor and some thoughts of the anemia, and the patient advised the CBC and PBC sent to the laboratory. But laboratory report gives like this, and the peripheral blood smear, the poor quality of the smear, no opinion possible. What could be the diagnosis? Every time you have the patient several times has been PBC slide has been sent, but the patient having this type of smear. So probably this is that is the auto-agglutination of the blood, and that is most commonly is a cold agglutinin disease is the possible diagnosis here. So every time when your denatured or RBC is agglutinated, every time they think of the autoimmune hemolytic anemia or cold hemoglobin, cold agglutinin disease. So here the next step is that is the most important. So another is the fatigue for 2 years, big pain abdomen for 2 years, headache for 1 year. Most likely, this is we will call it as a simple case of psychiatric disorder. But on examination, the neck node is 2.5 centimeter, and on palpation, if you go for the palpation and you had a huge hepatosplenomegaly, hemoglobin low, WBC is more or less normal, every parameter is normal, platelet normal. So USG the only hepatosplenomegaly we are getting. Now, what is the important point? Here if you go for the further evaluation, bone marrow aspiration was done. In that case, leukoerythroblastic picture, we came out to a leukoerythroblastic picture, but bone marrow aspiration does not give any conclusive report, no opinion possible. Then we go for the trephine biopsy, and trephine biopsy in the trephine biopsy shows that patient having myeloproliferative neoplasia. Initially, it came out to be the bone marrow aspiration dried up, then trephine biopsy was done, and it shows hypercellular trilineage dysplasia, suggestive of the myeloproliferative neoplasia. On the neck ground, that we got an APIWB stain was done, and that is related to the came out to be the APIWB positive. And now, whether the bone marrow, this is actually coexistence of the myeloproliferative neoplasia with that of the TB positivity. So this is my last case. the 14 years old, fever, patient with the fever, pallor, lymphadenopathy, ecchymotic patches, and the hemoglobin like this, WBC is 19,000, platelet low, RBC normocytic, normochromic, and all other neutrophil is low, lymphocyte is high. Atypical, here is the important. Why the neutrophil is low? Because of there is an atypical mononuclear cells are there. So, and the patient presented these are the symptoms: loss of appetite, weight loss, discomfort in the bone, joint, enlarged spleen, enlarged liver, headache, and so on. So, as well as excessive menstrual bleeding because the platelet was 9,000. So this patient, lymphadenopathy, ecchymotic patch, some are thrombocytopenia is there, as well as atypical mononuclear cells are there. And these are the patient's skin picture showing a purpura, petechial rash, and on the peripheral blood smear. Why is this important? You can see that is the some sorts of monocytes is increased monocytes. And the patient ultimately undergone the bone marrow aspiration, and it came out to be acute leukemia. And these are the very important. When you diagnose a case of acute leukemia, you must go for this cytogenetics, and the immunophenotypic study is important for every leukemia patients. And now, because the problem here is the acute leukemia is there. Now, whether it is an ALL or AML, so immunophenotypic is the required. And the ALL, if it is ALL, whether it is a B type or T type, so again immunophenotypic is required. And if that is ML, then whether it is a translocation is there between the 15, 17, 18, 20, all like this. So in that case, you need a cytogenetic study. And if even in a case of dry tap that can occur in a subleukemic leukemia or in the myeloproliferative neoplasia, myelodysplastic syndrome, in that cases, the trephine biopsy is very, very important. And from there, histochemistry and the immunohistochemistry is very, very important. And here, after doing the histochemistry, immunophenotypic, it came out to be a case of acute promyelocytic leukemia, and it usually the PML RADA gene fusion is the important cause. And here, again, that therapy, again, I have mentioned earlier, here the case IATRA should be given, is to be given along with that of the arsenic trioxide or the gemtuzumab. And with this, there are so many cases, but because with the I want to stop here because of lack of the paucity of the times. Over to the chairperson.
Thank you. Thank you, Hamid, for your nice elaboration of the case-based discussion on anemia. Actually, you have discussed all cases of anemia, including a peripheral blood smear, how to study the peripheral blood smear and everything. And most important, you have mentioned about the right proper prescription. That is very important. Don't write in a case of a anemia patient like a hemoglobin TCDCSR. Just write down a complete hemogram with a peripheral blood smear so that the laboratory can give all the data so that you can diagnose from here. And you have mentioned about the iron deficiency anemia along with the thalassemia group and infection related anemia and different type of macrocytic or megaloblastic anemia. Now I go to the first the question box, whether any question is there. After that we'll discuss from our seniors about their comments and others. So, first of all, Dr. Sivendu Ghosh has asked about the peripheral blood smear in anemia. That I think he has discussed about that thing. Dr. Ghosh is already is here. So, can you specify your question, Sivendu? Hello, Sivendu Ghosh.
Yes, tell me. Now,
What
I was just
What is your
delivering.
question? And if you have given ask you any question, or if you have any comments, you please give your
Yes, question as already told. I think some of the basic features of RBCs, particularly, the helmet cell like in mechanical disorder, like you have already mentioned that valvular heart disease, valvular replacement, valve or patient having HUS or TTP can have a RBCs which looks like this. And about the some of the peripheral blood smear, in fact, few days ago, Prantor was showing that a 6 days baby were having all the investigation done for the anemia, and ultimately it was proved that the patient is harboring a malarial parasite. So that is one of the things that I was talking about, that peripheral blood smear, fragmented
So
RBCs, anocytosis, poikilocytosis, and these are some of the features which can direct us the a panel of discussion after we get a good peripheral blood smear. That's my idea.
actually,
And already, right. Yes.
actually, I had so many slides on this. Whatever you have done, if you give a permission, I give a slide on what are the point malaria parasites. I can share the slides if you want. I have so many slides, so many case discussion, but because of the paucity of the time, I could not
that
able
can be
to.
done by Udas Ghosh only. I cannot give permission. Udas Ghosh can say.
So the patient presented with like this, and came out to be a case of malaria. This case also is there in my case studies.
Yes. No, that's already discussed. You have discussed a lot, but that is my addition or
Yeah.
this.
Okay, sir. Thank you, sir. Thank
Every
you.
lecture is a time framing. So actually,
Yeah.
we
Okay.
have to complete it by a 1 hour time. That's why
Yes.
time for a 45 to 55 minutes like a discussion, another 5 to 10 minutes for five to 10 minutes for discussion, and others. So it is important
Yes.
here mention
More
about
questions.
related anemia also. So you have mentioned that one. That is a very good idea. Any other points you want to mention? Or if you ask any question, then because there
Yeah,
is
I have
no
already
other.
asked in the chat box about the blood transfusion in DAT positive hemolytic anemia. Probably it is available. DAT positive hemolytic
That positive.
anemia
Okay.
for blood transfusion.
So preferably it is not to be done unless and until it is very, very required. If I have to treat with the first and foremost important is the steroid, and if the steroid is not working, or if the patient has severe bleeding, you can take the help of the other IVIG or like this. Blood transfusion should be delayed until till to the end. It's preferably not to be given, because it will cause again the hemolysis, and the other patient will, like that of the ITB patient, you don't give the platelet transfusion. Here is the same rule. You don't transfuse the RBC in a case of hemolytic anemia until and unless it's a very, very emergency or active bleeding is going on like this.
Now, another question is combination of hemoglobin disorder, anemia with peripheral neuropathy, because we see lots of patients who have got B12 deficiency without anemia, and some are with anemia. So neurological symptoms and neurological sign symptoms sometimes is dissociated with anemic symptoms in B12. What's your experience? I'm not talking what is written in the books.
But
We
actually,
find lots of patients. Yeah.
Actually, it's my experience is that some patients comes with the paresthesia, tingling, numbness, and on CBC, I found the patient having non-anemic, but the MCV is high. So in 2 or 4 cases, I ultimately diagnosed a case of megaloblastic anemia, and not the anemia, the B12 deficiency leading to the tingling numbness. So here is the clue to my diagnosis was that of the high MCV on the background of tingling numbness.
Professor M.K. Rai, you have any comments about that? The MCV is high, neurological symptom with hemoglobin low, and unmute, sir, unmute, please.
It is everybody's experience. Almost in every clinic of your private chamber or in the hospital, you are probably coming across with the patient with a tingling and numbness. And common things should be, if you look, if and find that there is a mild anemia and MCV is high, in that situation, always we cannot go for you can go for the B12 and folate, but then you can go for a trial with a simple medicine for the B12. And most of the times, the ophthalmoscopy is very, very important. I request everyone, whoever comes with a peripheral neuropathic like picture, tingling and numbness and suspect in B12, look for the fundoscopy. Fundoscopy will give you some idea whether there is any chance of any optic nerve failure. That means the beginning part of the whole story. A lot of cases I have come across with later and develop a lot of optic nerve problem. So if you find this thing, your diagnosis is very clear. If you do not find, you give a trial with the B1, B6 and B12. Combined we generally give. I'm just telling in a very simple way what we do. Not always very specific, but it is very common. Especially in vegan people.
Okay, sir. Thank you. One question to Hamid. He has also Chivindra also asked about the few comments on dimorphic anemia.
Yeah. So dimorphic anemia, the most common, there may be an early stage of the, there may be that there is the deficiency of the nutrient like the iron deficiency anemia there, as well as the the B12 deficiency, folate deficiency is there. In that case, the combined deficiency is commonly present as a dimorphic anemia. But the most important, more theoretical point of view, the dimorphic anemia is a feature of sideroblastic anemia. The sideroblastic anemia actually have a dimorphic anemia, but we in our clinical scenario, we often found the patient having iron deficiency as well as a B12 deficiency. That may cause a and another important that is the iron deficiency anemia in the presence of hemolysis. There may be the hemolysis itself can sometimes can causes the macrocytosis in some cases.
Thank you. Actually, can you give an answer, particularly for the postgraduate? We can come across a patient of anemia and we have diagnosed that it is a case of a thalassemia trait, but ferritin level is a very low, 5. Then what to do in that patient?
Okay.
Low ferritin with a thalassemia.
So that means here is the ferritin, the hemolysis is very, very less. The iron, as the iron store is there, ferritin is low. So that may be whether there is other features of iron, the serum iron is low or not. If the serum iron is low, along with the ferritin, so here you have to go for the serum iron. If the serum iron is low, in that cases, you must have to give an oral iron therapy. No problem. You can jolly well give the iron therapy in this group of patient. I often, there's so many, this type of patient comes to my chamber also, and I often prescribe the iron with the frequent follow-up of ferritin. So don't let the ferritin to go above 100. Try to let it below 50 and you give an iron therapy for 1 to 3 months and ask the patient to come with the ferritin and the serum iron within 3 months. If it is less than 50, you go and continue for another 3 months. If it is beyond the 50, then you preferably stop it and you again ask him to come with that iron ferritin like this.
Hamid, one second. Can you enumerate the other causes of high ferritin level for the postgraduates? Other causes of.
So that means high ferritin usually indicate of anemia of the chronic disease. So thalassemia, all hemolytic anemia, as well as the anemia of the chronic disease. So when you find a high ferritin, that is, you have to think of the anemia of the chronic disease. So low many lists, the collagen vascular disease is one of the very important cause. Malignancy, lymphoma, leukemia, myeloproliferative disorders is there. So all sorts of chronic infections, even the TB, fungal infection, what can come as a high ferritin level.
Would you advise serum hepcidin level in those cases?
Okay, I have mentioned already that if the patient is in a dilemma, whether that is the iron status, I'm not getting a clear picture from the investigation, you can take the help of the hepcidin. In hepcidin, it will differentiate with iron deficiency anemia with that of the anemia of chronic disease, as well as the I have mentioned about the zinc protoporphyrin and the heme ratio is also important.
Thank you, Hamid.
So Hamid, another case I have just seen few days before, a case of a iron deficiency anemia with a ferritin is very low. Patient already diagnosed as a clinician by a case of a iron deficiency anemia, not doing all the tests. And when I've done all the tests, if the ferritin is low, but the iron is very high and TIBC is very high, transferrin is very saturation is very high. What is your comment about that?
Ferritin low and iron is high.
Ferritin low, iron is high, TIBC is high,
So,
and
ferritin low. Uh,
so actually, in these cases, when the iron patient is taking iron very high, he is taking more than the actual dose. So if basically iron overload with a very small period of time, and if you do the blood test like that, then the ferritin is not transformed there. So ferritin is not increased in that time. So in that time, you have to reduce the dose of iron and gradually, and then body will gradually, take the iron and form the correct the hemoglobin level. So it is a judicious, rather a very much excessive dose of iron is given to him. That's why the iron load is very high and ferritin is low. So, Dr. Ganguly, have you any comments or any question?
I have any comment because the one-day workshop on iron deficiency anemia with the Hematological Society of India, what knowledge I achieved that in India, iron deficiency and vitamin B12 deficiency is almost equal. Iron deficiency and vitamin B12 deficiency is almost equal, and in most of the patients, they coexist. In the Indian, the vegetarian state have a very much vitamin B12 deficiency. India, the Gujarat has the highest GDP, but also have the highest number of anemic patients in India. Whereas Kerala, having a middle GDP, have lowest incidence of anemia in our country. So the cause of anemia is nutritional deficiency and also some food habit. So when we come across a patient of anemia, vitamin B12 is also to be considered. May not be MCV that high. And one thing that they are telling, but this is a mainly academic question, that in cases of vitamin B12 deficiency, vitamin B12 may be a low normal, but if there is hypersegmented poly or thrombosis in any part of the body, then homocysteine level should be done. Hyperhomocysteine level and low normal vitamin B12 level is an indication of vitamin B12 deficiency. Vitamin B12 deficiency give rise to anemia, neurological symptom, and also thrombotic symptom, CVA, due to high homocysteine level. This knowledge I have learned from one day workshop with them.
Thank you, sir. Thank you. Actually, there is a two question from the attendees. I think they are postgraduates. One is from Dr. Aninder Sarkar. He has a question: is that I have just 1 minute. 1 minute. I have faced some cases of isolated hemolytic isolated normocytic normochromic anemia. In practice, no significant history was found to locate the cause. Only common factor was all patients are greater than 40 years of old. Other blood count, peripheral bloodemia, creatinine, thyroid, inflammatory markers are normal. Is there anything more to be done before the bone marrow examination? Isolated normocytic normochromic anemia in practice. Patient is aged about 40 years with all the renal and other parameters are normal. So what to do before bone marrow?
So actually, in that cases, whether there is an anemia of the chronic disease must be excluded here. The most important point here, the case history, whatever has been written, the anemia of the chronic disease to be ruled out first. And in that cases where you have to go for the ferritin level should be checked whether it is very high or not. Inflammatory markers are high. ESR is whether high or not. That to be kept. CRP is the care. And whether the bone pain is there and the multiple myeloma also to be ruled out here. Though the creatinine is may not be high in the early stage of the multiple myeloma, only the hypercalcemia is there or not. If the low back pain is there, hypercalcemia is there, and the chronic inflammatory marker is positive, then you may think of the so many causes, the chronic anemia of the chronic disease. That has to be dependent, that has to find out from these cases. So X-ray, USG, X-ray chest, USG whole abdomen, and the X-ray low back pain, and the lumbosacral spine. And probably these and the urine REME or in the fungal infection, tuberculosis infection, MANTU test to be taken care, the collagen vascular disease there or not, whether polyarthralgia is there or not, polyarthritis. So there's a collagen vascular workup should be done. So probably that means in one word is the anemia of the chronic disease to be ruled out. I think this is the most important point here.
Really, it is true. Thank you. I think Saurabh has another question. Saurabh, can you say directly? Hello, Dr. Saurabh Pal?
Yes, sir. Good morning, my respected teachers.
Just you tell what's your question?
Sir, we come across lots of autoimmune hemolytic anemia patients in our day-to-day life. So we usually prescribe prednisolone, the oral steroid in 1 mg per kg for body weight, and we wait for the response. So my question is, what should the target hemoglobin for those patients? Till then, do we need to continue the steroids, and in what dose, and till how long we should be continuing those steroids? That is my.
Thank you, Saurabh, for your questions. First important point is the target. Target is not more than 8 to 10. 8 to 10. That's depending on the clinical scenario. 8 is sufficient in a case of autoimmune hemolytic anemia. But if the patient having some sorts of the cardiac disease, then you may have to increase the dose, increase the level up to 10. The next question. Yes, you have started the steroid for 1 milligram per kg body weight and the patient responded. You try to gradually taper off over the period of 2 to 3 months. And if the patient responds and if the patient very low dose of steroid is required, only 5 milligram or 2.5 milligram per day, then you can continue it for the rest of the life. But if the patient does not respond, what will you do? That is your question. The most important part here is that if the patient is, you are giving a 1 milligram per kg body weight of steroid and it is, the response is not satisfactory, or even the response is satisfactory, but when you are trying to reduce it, gradually reduce it, then again the flare up of the autoimmune hemolytic occurs. In that scenario, preferably you try to reduce the dose of the steroids and add an azathioprine like this. The steroid sparing agent should be added on this background. And then you add on azathioprine, increase the dose of azathioprine and reduce the dose of steroid to a minimum level and continue for the rest of the life and go on follow-up.
Okay. Thank you.
Anyway, that's also the Dr. Ganguly is there. There is the role of rituximab, there is a role of splenectomy is there. So you have to rather consult with the others also to see that one.
So that is another mode of treatment.
Dr. Udas, can I make one question? Yeah. Can I make one comment on this part? Dr. Udas?
Yeah.
One comment. Actually, if the patient is of reproductive age group, having hemolytic anemia, not responding or responding partially or responding well, then again having features of recurrent hemolytic anemia, you have to exclude the dose, particularly in a woman of childbearing age. Don't think that hemolytic anemia is the only one manifestation, is maybe the part of the SLE or other collagen vascular disease manifestation. Even lymphomas can present hemolytic anemia as the initial presentation. Cold and warm antibodies positive. So Yeah. That is my
the most important picture of hypothyroidism is the if you go for the peripheral blood smear, you will have a macrocytic anemia. That's very, very important. So macrocytic anemia is one of the major features of anemia and hypothyroidism, but it may be associated with that of the other associated because it actually the hypothyroidism causes maturation defect, because all the hypothyroid thyroid drug actually causes maturation. So it does not cause maturation. So the maturation fails, and the but iron hemoglobin formation is sufficient enough. So that's why it causes the failure of maturation leads to the macrocytosis. I think that this is the most important clue that will give a anemia of hypothyroidism, but there are so many causes. It may be associated with the iron deficiency anemia because the hypothyroidism may be associated with iron malabsorption, reduced iron absorption in a case of hypothyroidism. So that may present as a iron deficiency anemia also, but mostly it present as a macrocytic anemia.
Yes, it is a very good Manojit, is also our clinical teaching that if a
Thank you, Udas, and also Hamid, for your wonderful illustration and discussion. And also, I render my thanks to Dr. Udas, our host, for his excellent chairing this session. Now I request Dr. Ananda Bakchi, who is the chairman of API West Bengal branch, to give vote of thanks.
So thank you, Dr. Amal Banerjee, for giving me the chance to give the vote of thanks. First of all, I thank Dr. Hamid Ali for his excellent deliberation, excellent illustrations, and overall excellent performance. I thank Dr. Hamid once again. I also thank Dr. Udas Chandra Ghosh for successfully chairing the session and putting all the questions. I also thank all the attendees who have attended, and if they have benefited, this is the success of our this master class. At the last, I once again thank Dr. Amal Banerjee, ICP chairman, for giving me the chance to give the vote of thanks. Thank you all. Thank you very much.